All right, I'm going to talk about chondrocyte implantation, same disclosures, and I do want to point out that this presentation will demonstrate some off-label use of chondrocyte implantation and on the patella, and the use of a BioGuide collagen membrane that is an off-label use of an FDA-approved product, which I'll point out. Here's this little kind of diagram of how the literature has gone on chondrocyte implantation. One publication in 1994, 407 in 2010. So certainly it's a tribute to my good friend Lars Peterson, who was the spearhead of that first publication in the New England Journal of Medicine, that it's become such a hot topic worldwide. What I'm really going to do is talk about some specific issues. The difference in the outcome between the various kinds of ACI that are practiced both in the United States and around the world. How has the ACI technique changed in the U.S.? Can patients with ACI return to sports? And is there an effect on the outcomes of ACI after prior microfracture? And who are the best candidates for ACI? Indications, as you know, large symptomatic full-thickness chondral defects that have failed some form of treatment, failed other treatments, femoral condyles and trochlea in particular. It's not indicated for bipolar osteoarthritis. Patients 15 to 50, but since Darren's here, we got to make it 55. Significant, that's all right, Darren, I'm past the point, I can't have an ACI. So significant impairment, compromised activities of daily living, inadequate response to other cartilage repair techniques, and they must be capable of a rehabilitation program. They must be able to sort of follow directions, which, as you well know, is not all patients. Typically, these are larger defects. In my over 500 ACIs, I think the average size is 5.6 square centimeters. Distal femur, condyles, and trochlea. I'll talk specifically about the patella. No bony involvement. You can treat bony involvement up to about 6 or maybe 8 millimeters. Certainly more than that, or cystic cavitation requires a separate bone grafting. Comorbidities must be corrected either concomitantly or prior to the implantation. So whatever it is that's causing the hostile environment in the knee, the copathologies, instability, malalignment, meniscal deficiency, those things all need to be addressed. And I think the key thing about comprehensive treatment of cartilage is you really have to be kind of a comprehensive knee surgeon to be able to offer all these things. Because if you try to go short on any one of these steps, the patient will fail, and you'll have wasted your time on the other steps. So I think that's really the key. The patella is an off-label use, but with realignment, with addressing the copathologies in the knee, the results are very much improved. So here's a patient with patellar subluxation, and although there's kissing lesions in a 28-year-old patient, adding the anteromedialization of the tibial tubercle at the time of the ACI certainly greatly enhanced the likelihood of success. Here's a patellar defect, pretty much a large patellar defect, traumatic in a 40-year-old. There's the implantation on the upper right. At 6 weeks, she had difficulty with motion, so there's a lysis of adhesions. It gives us the opportunity to see what the repair looks like at 6 weeks, somewhat soft but intact. This was done with periosteum. And then at a year, had the opportunity to again second look, just so that she could advance her activity. And you can see the patella looks certainly very, very back to close to normal, excellent tracking, and that correlated with return to activity. So what are the differences now between these techniques that you hear about? MACI or ACI matrix or ACI collagen membrane. Instead of using periosteum, which was originally described to hold the patch in place, ACI with a collagen membrane basically uses an absorbable type 1, type 3 collagen membrane to sew it in place to hold the cells. ACI matrix or MACI, which is practiced outside the United States, it's not approved in the United States, is basically growing the cells within a matrix, and the matrix gets put in. With the cells in layers, the matrix is what gets implanted. If we look at those studies, matrix or collagen membrane done in Europe and Asia, the results are not significantly improved over the periosteal results, and they're not significantly diminished. So they seem to be about the same. Their only problem is they're shorter. They're shorter term follow-up at this point, but the expectations are that they'll show the same durability that I mentioned before with chondrocyte implantation. The problem with ACI using periosteum, as it was originally done here in the United States, is a periosteal hypertrophy rate that led to reoperations up to 25 or even 50% of cases. I think my own rate was about 27%, and that's just for the patient would complain of kind of a clicking or catching within their knee. You'd go in there and the periosteum would have grown outwardly like an exophytic type thing. You'd have to trim that off, and oftentimes the layer of cells underneath would still be fine, the cartilage would be okay, and many of them went on to do fine, but just that kind of a reoperation rate is certainly not very acceptable to most patients. It was advantageous as we developed this technique, as it gave me a chance to see an awful lot of second look knees that I wouldn't otherwise have gotten to see, but it taught us that you really didn't need to do this if you could help it, because the cells stayed in place and grew the vast majority of the time. With the collagen membrane, we've cut that percentage down to about 1% reoperation, so obviously pretty dramatic. Here's what BioGuide looks like. It's a collagen membrane. It's made from the submucosa of pigs, of the intestines of pigs. It's like a piece of felt. You just reconstitute it with saline or cells. It's very, very workable. It doesn't need to be oversized. You trim it to the size of the template that you're going to put back in, and it does have a more porous layer that actually helps produce a cartilage-specific matrix that's placed towards the defect. Even what I call poor man's Macy, you can actually seed that layer with cells. Take some extra cells and seed it on that rough edge. It's been described in arthroscopy out of Germany by Steinwachs, and although I did it empirically, once he published, I could say that I actually do it, where I implant the cells with the collagen membrane. I've been doing this now for about 3 years with the collagen membrane. It's become really the standard in the United States from a standpoint of greater than 75% of people are doing this BioGuide. It cuts down the operative time considerably. It cuts down the post-operative complications. Patients recover much quicker. They have essentially no motion problems, and the smoothness of the motion has been the most impressive thing to me, and the lack of the effusions that I saw before. So I've actually found it to be dramatically different using the implant. You can see in the lower right, there's a trochlear lesion that's been repaired with the BioGuide and the cells underneath. All right, what about returning to sports after ACI? 72% of soccer players at 3.5 years found or returned after ACI with periosteum. 83% of competitive players returned, whereas only 16% of recreational players returned. 80% returned to the same level of play and maintained it up to over 4-year follow-up. The patients who returned to competition younger, shorter pre-ACI symptoms, and unaffected by the presence of concomitant procedures. In other words, if they had an ACL tear, as long as that was fixed, it was okay. So that wasn't a negative influence. 96% of 20 adolescent athletes returned to sport or had good to excellent results, and 60% returned to sport after ACI. And so the return to sport, again, correlated with shorter preoperative symptoms. So not the chronic, I've been sore for 10 years, but I've been sore for 4 months. Lower number of prior operations, and those were the key. Those that were less than 12 months, high percentage return. Those that had symptoms more than 12 months, only 33% returned. And I do note that during the course of time at the NFL Combine, 3 players have come through that have gone on to the NFL tryouts that have had ACI, one in 2007, 2008, and 2010. So certainly it's compatible with returning to full-level sport. I've had collegiate players return as well. Post-op rehabilitation, pretty much as Darren described for meniscal transplant, it's based on the size of the defect. Large defects go a little bit slower up front. Smaller defects that are well contained can go faster. We're much more aggressive with rehabilitation now than we've been previously. Here's another one of those illustrative cases. As it goes through, we've had the opportunity to look at this patient 3 times. At 5 months, it's kind of soft like firm tapioca. At 1 year, it's now firm, looking very much like the surrounding cartilage. Returned to full activity. At 3 years, the reason we scoped him at 3 years, the guy's an orthopedic surgeon. We're doing his shoulder, and he said, hey, let's look at the knee at the same time. So that gave us that 3-year view, and certainly as he'd returned to full activity was nice to see. Influence of prior treatment. This is a study done with looking at patients who've had prior microfracture compared to those who haven't had microfracture for the lesions. Groups were not different in age or defect size, and this was by Tom Minus, but basically shows that prior marrow stimulation treated lesions had 3 times the failure rate of non-treated lesions, 26% failure versus 8%. Didn't matter what kind of marrow stimulation technique was used. And what's really interesting is talk about a control had 15 lesions or 15 knees where 2 lesions were treated within the same knee. So you've got 1 virgin one, 1 prior microfracture, and if that happened, 16 of the 17 prior marrow stimulations failed, and 2 of 15 non-treated lesions failed. So the marked difference within the same knee. But that's just an example that I have from last week. This is a patient who had prior microfracture here. This is a virgin lesion of the lateral femoral condyle. And just look at the kind of osteophyte that's in there, the exposed subchondral bone. It's kind of no wonder that we can't expect the same kind of outcome. Oh, I've got the wrong one. And that's that intralesional osteophyte that occurs up to 33% of the time. Been shown in several studies, just some close-up of what they look like. Obviously, it makes sense. The body's responding to the increased stress and the fact that the microfracture kind of overhealing. So in this case, prior microfracture may burn a bridge for these for subsequent treatments. So I'd caution you against just doing microfracture for the heck of it in a large lesion where we know they don't work, in the patella where we know they don't work, trochlea where they're certainly less likely to work. Don't do it casually, particularly for large lesions, because it may well burn a bridge. So in summary, there really isn't any difference between the various ACI techniques. The BioGuide that is used in the United States has decreased periosteal hypertrophy to about 1%. There's a high likelihood that young patients can return to sport after a chondrocyte implantation, particularly with shorter duration of symptoms. There's a 3 times higher failure rate in lesions that have been treated with prior microfracture, so we need to be careful and make sure that, that you don't burn bridges in lesions that don't have a good chance of recovery from microfracture. In summary, the best candidates, younger patients, symptoms less than 12 months, large lesions on the condyles and trochlea, isolated defect, absent or treated co-pathologies. The technique of ACI has shifted away from periosteum in the U.S. to use the BioGuide, to avoid the increased periosteal hypertrophy and increased operative time. And ACI is now done with the BioGuide at least 75% of the time here in the United States. Thank you.